let me ask Harry, epidemiologist, population scientist, and cardiovascular. Tell me what you think. Is it possible to go and replicate something like PSA in prostate cancer with coronary disease?
So I guess first of all, it's of course not or, so it's all plus plus plus. So the primordial prevention, the screening, and trying to do this is simply crucial. I mean, in this field, with the three things together, you can really do a good job, and you are already doing a good job. So yeah, if you can find a test that predicts mortality in the next 2 years or so, I think, except for people that don't want to know whether they are dying, for many other ones, you have very good therapy. So it would be really crucial. Of course, in this respect, I would imagine that the calcium scoring is such a good test at the moment that you should come up with something very very good to beat with that, basically. Yeah, or complement or whatever. But I think it's a good initiative.
Thank you.
I'm a little skeptical. I want to come back to what Jagat said. If we talk about the test, whatever the test would look like, and I mean, he mentioned the patients regarding normal plaque. You identify, more and more specific, but small population, and still the vast majority in that one, zero events. Well, with these specific criteria, even the vast majority of them, I still came from those who did not have those. So I'm a little bit skeptical.
You're skeptical about finding one single test?
Yeah,
I am with you 100%. I don't think we will be able to find a PSA. What I think we should be able to find is a combination of that vulnerable patient plaque. Can you go back to the circle? Plaque, blood, and myocardium. If you're able to draw something that combines these three and whatever other information, obviously age and all the things here, machine learning, again, this is not something that you and I are going to come and sit down and put a binary score. This has to be done with, huge processing ability and the unique type of data set that we just talked about. Those people who have had an event a few days to a few months.
But obviously, you also have to adapt these approaches to the different scenarios that we have talked about. I mean, you go from primordial prevention to these very, very high-risk patients. I mean, these are totally different scenarios. So,
but we're not going to change the primordial. That's already there. I think Harry just said that. Then we need to have multi-pronged approach. That will stay. The society level, even Dr. Fuster's approach to home and family-based education has to be there. There all has to be there. What we are trying, past 15 years focusing is the identification of the vulnerable patient, people who are right close to the cliff, and they're just blindfolded and they just fall, and we don't have any way to identify them. And cholesterol and other risk factors are not cutting.
The problem is that we will have to
screen.
Go to a very big population to get a very small result. That is our problem in this whole issue. For example, I tell you, we presented one paper in ACC this year, and then we just completed a survey based on that, which we submitted for this coming year. This was the women who went for their mammography. I don't know if you checked on that.
Yeah, I saw it.
Now you do the mammography and you find the breast arterial calcification in them. And this Khurram was here, right?
Yeah, he left.
Yeah. So Khurram did an editorial on it, fabulous editorial that he wrote. So the approximately 40%, 42% of women had breast arterial calcification. That was a biased sample. The reason being that we picked up only those who had mammography done as well as a CT scanning, CT of lung done. So we did the ungated calcium scores. And we find out that 47% of those women, and these are all 40s and 50s, where you would not do any kind of a test in these women, right? 47% of them have concomitant coronary artery calcium also, right? So Khurram did the analysis on it and beautifully written that we do approximately 40 million mammograms a year, right? Out of 40 million, even if we say that this was an absolutely biased population, 4 times biased population, at least we have 10% of them who have a likelihood of having calcium in their coronary artery, which otherwise we would have never thought in these women.
Well, you already answered that question.
So you have now 4 million women, right, every year who are likely to have the coronary calcium. Okay, and now what do we do with these women? So basically, we will tell these 4 million women that okay, you go ahead. I mean, 10%. So out of them, 47% have. So 2 million women. What do? You change their lifestyle. What do we say?
I think you just made the argument. You just said we're trying to do multiple ways to identify them.
Right.
But according to
so I tell you. So today we did we submitted the late-breaking abstract today for ACC. We find out that 85% of them said that they want to be informed and they would like to find a remedial measure. Now, I don't know how far would it go, how many of them will accept it, what change would it bring, I have no idea. But they want to be informed.
I think that's a great movement. I mean, that's a great step up. We should put that in national policy, like FDA, CDC take this as a guideline.
National policy will take it, but
I mean, we were just talking about that to make a change, meaningful change, it has to be multifactorial. And so social impact and social education and guidelines and policies are one of them. But, the SHAPE group said collectively that the first cut should be knowing if you have zero coronary calcium or you have a lot of calcium, because that will give us a good starting point. And then from there, we build on whatever machine learning tells us, guide us that adding these will bring you to that, that threshold. Late George Diamond and Sanjay Kaul, after our SHAPE guideline was issued, they did the analysis. They actually said we need to screen about 48, 49 million people. But it's not every year. First year we do this, we get a cut, and then every 5 years we would do it. So they did a very beautiful analysis, and back then they said it's not cost effective because they put in their cost $400 for coronary calcium. I think Dan can testify here that we can do that with $80 to $100 now. And if you put $80 to $100, it would be significantly more cost effective, truly cost effective. So, our approach is, this is the mammography of men, kills more men than, breast cancer killing women. It should go to national guideline. It should become a standard of care. You get your coronary calcium, you know where you are. Now we're working on finding the vulnerability factors that maybe with Johannes and Piotr and other people looking into calcified vulnerability or vulnerable calcification, it might even be able to improve that one even further. We're just looking at the great Addison score, right? We haven't made any improvement in that one. So if you add those incremental, we can very likely reach that 25%, Dr. Brownwald, or even more. And once there, I think we'll reach the holy grail. We will reach that era that we've been chasing for 20 years now, 50 years, that we turn these people to like cancer, tumor. Now we got to do something aggressive and try to serve while we're doing all other things, just societal levels and so on.